The business of healthcare is hard, creating a badlands of terrain that is difficult to navigate. Some think the most brilliant minds in business are on Wall Street. They are wrong. The most brilliant minds are in healthcare. They have to be to thrive and survive. This podcast explores concepts in leadership, management, sales, and negotiation with those brilliant minds. The Healthcare Badlands podcast is generally planned, but unscripted, unedited, and uncut, so you get the honest and unfiltered experience. Your host is Dr. Tom McDougall, a 30-year veteran of healthcare with 23 years of hospital CEO experience. His guests are carefully selected experts from across the industry. They offer insights, expertise, and some great real-life, often hilarious stories. Now, let's jump into the episode.
Welcome to the Healthcare Badlands podcast. Today we have Paul Theriot. He is a former hospital CEO that's transitioned into physician practices. He is the executive administrator and CEO for Birmingham Gastroenterology, a very large group of gastroenterologists that is independent. So, Paul, glad you're here with me today.
I'm super glad to be here. It's been a lot of fun kind of catching up.
Yeah, absolutely. All right, so we're going to jump right in. And I know there is a topic that we discussed in advance and you want to talk about, and I think it's an excellent topic because not everybody understands it, and it's the concept of tragic alignment. So talk to us, Paul, about what tragic alignment is and how you believe it's impacting healthcare organizations now and in the future.
Yeah, it's a phrase that I kind of use. There's a lot of interest in the sort of consolidation in healthcare, and that is what we used to call in business school vertical alignment, where you have entities that are sort of owned by the same organization, but they have different functions. And I'm just going to use this as an example. When one entity owns the insurance, the pharmacy, and the physician group, those are things that are normally independent. They make decisions independently of each other. But when those things become sort of consolidated, you have this idea that, well, one person would have normally made a decision based on this criteria. Well, now they share this sort of alignment, and tragic alignment. It's a coarse phrase, but I think it's accurate. I mean, you have a situation where doctors are making decisions not solely based upon what they would have traditionally made those decisions on. They have which is ironic because a lot of legislation, as you know, over the years has been introduced that's supposed to kind of keep that barrier there so that doctors are not making financially influenced healthcare decisions. And yet I think it's out there, even more prevalent. It's just outside the hospital. And again, you and I, we experienced all of the growth of regulation around Stark and all of the things that we were limited in doing in terms of working with physicians as a hospital, but insurance companies, they don't really have that barrier. It's kind of the Wild West as far as that's concerned.
Yeah, and let's talk about that kind of from the different perspectives because, and I want to bring this up because when you were just talking about that, I thought about it. And about 5 to 10 years ago, I can't remember exactly when it was, but CMS, Centers for Medicare and Medicaid Services, that runs Medicare at the federal level and provides a lot of guidance for Medicaid, they paid for a consulting study, spent I think I remember $4 million on a consulting study to determine whether or not physicians order more of a particular service if they own it. And of course, this example, the most basic example is an orthopedic surgeon in their office. If they have an X-ray unit sitting there, which is a convenience to the patient, their $4 million study determined, yes, the doctor will order more X-rays. And of course, me being me, I'm like, what the hell? I mean, why do we spend $4 million on this? They could have called me and paid me $10 and I would have told them that was true.
That's right.
But where's the line blurred? Because there's patient convenience, because if I'm going to a physician office and they're going to need an X-ray and they're going to need some lab work, I don't want to have to leave there and go somewhere else to get my X-ray and my lab work. So there's an element of patient convenience that is there. But where is the tragic alignment not necessarily tragic, I guess is what I'm getting at. Let's stick with the provider side and then we're going to
Yeah.
shift over to this insurance side.
Yeah. So think about it this way. I love the illustration you just gave because you think of a pendulum. Okay, yes. Was there this sort of artificial inflation of orders? Probably. Well, now change that pendulum and go this way. Well, what happens when you tell the doctor, we're actually going to incentivize you to not order x-rays? So you're going to get paid for everything you don't do. Well,
Yes.
what if that patient needs an x-ray, but they're in that gray area? We'll just continue to look at it. And they don't order and you don't get the service. And now that physician's financially incentivized to not do some of the things he would have done. I think that's kind of the world we're living in now, and whether it's this sort of artificial depression of orders or simply through capitated payments, the folks that are really driving these decisions are the ones that just generally want to spend less money. And listen, we all have heard the reports about how much we spend per according to GDP and the largest healthcare expenditures. All of that's true, but I think that we've all heard the saying that we've got the best healthcare in the world. From an outcome standpoint, that's arguable. I completely get that, and I understand it, but I don't think it's because of the healthcare system. I think there's other factors involved, and you can't really say, well, the providers are subpar because our healthcare outcomes nationally are poor and we're spending too much money on it. I think there's so many other factors it's you can't really blame it on that.
Yeah, and I get super irritated when somebody says, anything, quite frankly, I think it's dumb. Why can't our healthcare system be like Sweden or Great Britain or
Yeah,
Canada or, and my default answer is always this smart aleck, well, we're not Sweden. I mean, the
exactly.
population of Sweden is about the same as the population of Atlanta, if I remember correctly. Could
That's
I
right.
design a
Yeah,
healthcare system for 8 or 9 people, 8 or 9 million people that is captured within the borders of a country and they don't have a whole lot of choice? Yeah, I'd probably come up with a plan for that. But
yeah,
but it's not the United States. And also the expectations there are so different. I visited Sweden years ago and I was fascinated by the lack of work ethic in that place. I mean, they don't
yeah,
work and
yeah,
everything. And we were told before we went, they said, be prepared. Everything's slow. Do not think you're going to get a quick meal if you sit down in a restaurant because they're just kind of going to do it at their own pace.
yep.
Um,
Pace is slow.
and, and it hit me though during the visit. Um,
Yeah,
I thought, I'm going to Google something. So I Google what is the effective tax rate on people who live in Sweden? It's like 63%. I was like,
yep,
well, okay, I get it now. I mean, if 63% of the money they're making serving me a meal in the restaurant is going straight to the government,
yeah.
I can see why they're not in a big hurry.
They're
And
not in a
so,
big hurry. They're not.
yeah,
Yeah,
so it's all intertwined in the society, the culture, all those different pieces. Okay, so going back to my question though. So
I'm not
where
answering your question.
no, I want to go back to it though because I don't think we fully answered it. And I'm not talking about your practice, okay? So I'm not
Yeah,
going to put you on the spot where you have to defend tragic alignment in your practice. Let's talk
yeah.
about your gastroenterology. So let's talk about
Right.
orthopedics. Let's go
Okay.
there. Okay. So, and I love orthopedic surgeons.
Pick
Some
on
of
the ortho guys. Sure.
my okay, but orthopedic surgeon. Okay, it is theoretically possible that the orthopedic surgeon could own not only the X-ray unit but own the MRI unit. They also could have ownership in a surgery center.
Yeah.
Okay. And so let's debate this for a second. Is that acceptable? Is it acceptable that they have ownership of all those different levels? And then before somebody says something, I get a smart aleck response. What if they also were part owners in the hospital? Where does the line get drawn where this alignment is no longer tragic?
All right. I'm glad you brought up orthopedics, and I'm going to speak generally, and then I want to get real specific with two different answers. So, generally, to answer your question, it is absolutely possible for it not to be tragic. And if the provider has more control over the time. I don't think that's a naturally tragic situation for the doctor to be in control of a lot of different components. And I want to give you a specific example that I was fortunate enough to work with, and that is, and those who hear this will know where I'm talking about. The the physician and you've experienced this. The physician had actually entered into an arrangement with the insurance companies to be paid a full bundled payment. We've all heard that phrase. So the physician received a bundled payment, the physician did, and he managed the supply cost, the implant cost, and rented the OR and the staff from the hospital. And the hospital, we hired, we had the staff and we had the building, and we just provided that. And he paid us part of that bundled payment. But you can bet that physician managed all of those pieces, especially as you know, a big cost of these surgeries is the implants and those types of things. Well, he was directly engaged with the vendor, and there was not this sort of a three-legged stool. Well, you put leverage on the hospital, we need this, and you choose this company that's going to cost you a little bit more, but you'll like the outcomes and all of those sort of things. Now that's all of that's off the table, and the physician is sitting there. Well, it worked phenomenally. And I will guarantee you the patients had really good outcomes because the physician controlled everything. He was truly the captain of the whole program. And I saw it be very successful. And I'll be honest with you, it was one of the major motivations for me to make this sort of professional pivot that like this is where it works. I mean, in the outpatient world is that's how things should be managed. And so I don't know if that helps, but I think it is absolutely possible to have alignment without it being tragic.
Yeah, and we've seen it also with cardiology. You know,
Yep.
we're about the same generation. So in my time as a healthcare leader, I've seen cardiology completely transition from one model to another model. The
Yep.
model that early in my career is the cardiologist owned just about everything. So
Hmm.
they owned their own cath labs. They were doing all of the imaging internal. And there was actually a large group that I was affiliated with at the hospital where I was. They did it all. They competed directly with the hospital, and they were doing well. And
Yep.
it seemingly was working just fine. Now we can debate whether or not they were over ordering or not. I don't have any reason to believe that they were,
Yeah.
none whatsoever. But now, fast forward, where a majority of cardiologists in the United States are employed by a hospital, a
Hmm.
majority.
Yeah.
And so people who are younger than us are probably, and I see you grinning because you know exactly where I'm going with this,
Yep.
but people would wonder, well, why did that happen? It happened for one simple reason. Insurance companies started cutting payments for these services that the cardiologists were investing in, and the
Yep.
margins eventually got small, which prompted some cardiologists to move towards employment. And then
Yep.
eventually the margins reached zero to negative.
Yep.
And when that happened, all of a sudden the entire model for cardiology changed. And it
Yep.
changed pretty rapidly. It changed in a really about a 5 to 8 year period. It was a dramatic shift.
Oh yeah. I think you saw something similar with imaging centers. You know, there's this massive proliferation of imaging centers around the turn of the century, and you had all of these things popping up. Well, when that reimbursement started going down, they couldn't offload those things soon enough, and now you've got, and we're starting to see it in ASCs. There's a lot of pressure on ASCs. Well, in my opinion, that should not happen. I mean, the ASC that is an area where we can do a lot of good work as a profession and have great experience for the patient in and out, not having to navigate the massive network within a hospital. They can get their surgeries and go home that night, which we all know they recover better at home than they would in a hospital bed. And we give them good instructions and they get the care they need. Uh, and to have that sort of squeezed, it's sort of disheartening, you know. But the payers should be looking at the ASC as the future, not the other way around, because we're going to end up back where we were, and there's not going to be any outpatient centers, and patients are going to have to go back to the hospital, and they're going to have to go in the same OR as somebody having a much higher acuity procedure,
Yeah.
and it's just not what we should be having.
Yeah. And I think our problem in healthcare is that we innovate the care appropriately. And that gets driven by a couple of different ways where we innovate the care, but then our business practices don't follow. And I'm going to give you a
Yeah.
perfect example. And it's a real life example, is one I just experienced. I've been married 32 years, fantastic lady. She's 56 years old, just like me. And 5 weeks ago, she had a hip replacement. And her hip had a lot of degeneration in the hip, and finally she was bone on bone, and she was miserable. And so it was a decision of, I'm going to go through surgery to get back to a point where I can do all the things I want to do. And that's where she was. She wasn't able to do the things she wanted to do.
Yeah.
But here's the interesting part to me, and I've reflected on it. And this morning we were even having a conversation about it. The actual surgical experience was fantastic. Well, and I didn't have to recover from it, but from my
Right.
perspective, it was fantastic. Okay. Because, met with the doctor, got the imaging done, confirmed what was going to happen, established a plan for the surgery. He does a 4-inch incision with an anterior approach to replace her hip.
Yeah.
We arrive at the hospital about 5:30 a.m. And by early afternoon, we're gone. And we
Yeah.
went home.
That's right.
And they had put her through the recovery process. Physical therapy had come and walked with her, made sure she could walk around enough with assistance
Yep.
with a walker, but she could do enough to go home. We didn't spend 3 nights in the hospital. We didn't spend 7 nights in the hospital. And then they set up the physical therapy. She went to therapy. And so here we are 5 weeks later. She's back to doing everything she wants to do. She just does it with caution. So before she bends down to pick something up, she thinks about it, but she still bends down to pick it up. And so the entire care experience has been fantastic. It's been fantastic. But fast forwarding to this morning, my wife walks in the room. I'm on the phone with the radiologists that were involved in this. And you're grinning. You know where I'm going with this. Okay. And my wife overheard part of the conversation. She said, "Was there a problem with my bill?" And I said, "Yeah." I said,
Yep.
there was a problem.
They
And
were out of network.
she said, well, this is what's bizarre is that, the bill came in and there is zero detail and it says we owe $77. Well, I care about my money. So
Yeah.
I know enough to go log into Blue Cross, go look at the claims data and see what Blue Cross says we should be paying.
Yeah.
So in 3 pages of claims for this year, I find zero that says the name of the radiology group and zero that says I owe anybody $77. Zero. But the bill they send me has no dates of service. It has nothing in there that says why they're billing us the $77. It just says you're supposed to pay it and it's due.
Wow.
And they provide a handy link for me to pay electronically.
There you go.
So me being me, I pick up the phone and I called him and I said, "I'm just trying to validate and verify that we owe you the money. If we do, that's great. I'm going to pay you. I got the online link. No big deal. But I can't figure out why I owe you $77 and the insurance company doesn't think I owe you $77. And she says, "Well, sir, if you'll look at the bill, there's a charge that is owed by you to us of, it was 30 something dollars." And I said, "Yes, ma'am, but I don't have that." And she said, "Do you not see it anywhere in your Blue Cross data?" And I said, "I don't." I said, "But nowhere in my data with Blue Cross does it say Birmingham Radiology." "Oh, well, that's because it's going to be by the doctor." I said, "Well, ma'am, how would I know which radiologist read an imaging study?" She said, "Well, I don't know that." I said, "Okay." I said, "So we're 40% there." I said, "Let's talk about the remaining $40 that you owe me." She goes, "Oh, well, that was a different data service." I said, "Okay, was it a different doctor?" She said, "Well, I don't know." I said, "Can you look in your system?" And so you can see where this was going. Okay. So,
Oh my
we
gosh.
finally land on that they have billed me for 2 services, 2 different doctors, neither one of which are bill, even though I get the bill from the name of the group, I have no
Yeah.
idea what I'm looking for in there.
Yeah.
The short version of this story is we did, in fact, owe them the $77. We did, but it was 2 different dates of service, more than a month apart, 2 different radiologists, and combined, they sent me a bill for the combined amount, which I couldn't match anywhere in any of the records with our insurance company. And so my wife catches the back end of this, and I get off the phone and she says, "Is there something wrong?" And I said, "Well, no, nothing's wrong. It just was super confusing. I got it solved. I'm about to pay it." And she said, "For radiology." And I said, "Right." I said, "It was your 2 imaging studies you had before you had your hip replaced." And she said, "Oh, I wouldn't have even thought about that." And I said, "Yeah." I said, "Let me take this to the extreme." And I said, "You didn't have an ER visit, but let's just hypothetically say that a patient shows up in the emergency department and they know from their insurance they owe $150 for that visit because that's their copay. So, but let's assume also this patient ends up having surgery following this ER visit. So they come to the ER, they're seen in the ER, they're admitted to the hospital, and they have surgery. I said, when they leave that hospital, they are expecting to get a bill from the hospital, but that's not what they get. They do get the bill from the hospital, but they also get a bill for the ER physician. If there
Yep.
was imaging done while they were in the ER, they're going to get a bill from a radiologist. If
Yep.
there was lab work, they're going to get a bill from a pathologist. The surgery, they're going to get a bill from the surgeon. They're also going to get a bill from the anesthesiologist. And odds are pretty good they're going to get a bill for the CRNA that was in the case. And I said, but the patient was expecting $150 when they went to the hospital, and nobody tells the patient, I'm going to order an imaging study. So the ER doctor or the nurse or whoever doesn't ever say to the patient, the doctor wants to get an MRI to verify whatever. And oh, by the way, when you leave the hospital, you're going to get a bill from the radiologist that read the image. Nobody tells them. And so
Yeah.
it's just this, it gets back to my point is that we have significantly innovated the care experience, but we have done nothing to innovate the business side of this equation, other than we make it handy where you can go to a link and pay online and not have to find a stamp and go to the post office.
Yeah, that's right. I gave a talk a couple of years ago about, if you look at healthcare as like this hub and spoke model, and we love hub and spoke models, but you and I grew up in a time when the hub was the hospital, and I think even a lot of the Affordable Care Act legislation was drafted with this idea in mind that, and because you remember back when it was first passed, there was all of these things that we needed to do to manage services that weren't even provided by the hospital. There was all these things about case management that was expected that it's like, wait a minute, we don't even have home health. Well, the hospital needs to manage that home health utilization and get prior auths and all these sorts of things. And well, I think it was based fundamentally on this idea that the hospital's in charge of this community, and I'm speaking in big high level terms, and then they will manage those, and we'll make sure that the hospital financially is a reimbursed but also held accountable for good outcomes, that whole triple aim. Well, what's happened though is you've had a decentralization. It's not, so you still have those requirements, but now you've got others that are financially incentivized to A, collect what they're due, but B, they're not going to coordinate, the surgeon's not going to coordinate with anesthesia. I don't I can't worry about whether or not anesthesia is in network. That's why I threw that out there, because we're seeing that a lot more in this whole, transparency stuff. Well, the surgeons say, I got my own things to worry about. I'm negotiating my contract with the payer. I'm going to do your surgery. The hospital's got a contract with anesthesia. You see, this sort of decentralization now has created problems for the patient, like you just described, where we're all kind of having to handle it ourselves. And yet the patient went to the hospital thinking that I'm going to hospital A and I'm going to have a procedure done, and I'm going to owe a bill. Like you said, $150 is my copay, not knowing that the last 10 years, it's kind of blown up.
Yeah, it's turned into Pandora's box. This episode is sponsored by CO Management Solutions, a revenue cycle company you may not have heard of, but you need to hear this. There is little healthcare organizations can do about inflation-related expenses, but you can make sure you're collecting 100% of your revenue you have earned. CO uses AI and the latest technology paired with an efficient team to aggressively collect your hard-earned revenue at an attractive commission. Start today with a free analysis of what you are leaving uncollected and recover that revenue quick with CO. For more information, visit coms.com. That is SCIOMS.com. Going back to our beginning discussion was where does tragic alignment become tragic on the provider side? And there isn't a definitive answer on this. It's almost more of we should look at it with an abundance of caution. Is that fair?
That's right. Yeah. And the idea, my wife's always doing this when she's like, well, this town needs to put up, they need to put in a Dollar General. And I'm like, honey, that cities don't put in Dollar Generals. That's not what they do. They need, they create environments for businesses to come in and make an investment in real estate and brick and mortar, and then they run the operations. And I think there's that same sort of assumption, in healthcare that, well, we're gonna make this happen, and it's just gonna happen, and it's like there's no thought around. Well, there's a lot of free market dynamics that have to all work in concert to create this outcome that you want. And to the point about, well, when does alignment become tragic? It's a case by case basis. And I think alignment is good. We should have alignment because it's the fragmentation that creates problems. Go back to my orthopedic illustration. The patients that were in that program loved that program because of what you just explained. They got one bill. Yeah. They got one bill from the orthopedic group, and everything else was handled on the back end or behind the curtain, so to speak. And wouldn't it be great if more things were handled that way? And, the point person was the person that as a patient you go to see. I'm going to see Dr. McDougall. Dr. McDougall is going to diagnose my condition and he's going to take care of me. And generations ago, that was the relationship. And he, again, managed the whole entire episode of care. Now it's just really fragmented, and you have all these alignment issues, which can potentially lead to some adverse alignment, tragic alignment.
Yep. All right. I'm going to ask you a question. You don't know what's coming, but it just popped in my head, and I'm curious about it because you've got a gastroenterology group. And I had years ago, I had a group of gastroenterologists that came to the hospital and said, we'll do our cases there, but we want to have our own pathologists. Well, the hospital had an exclusive contract with the pathology group that covered our organization. And I liked that group, and I liked the relationship I had with those physicians. They did a good job for us, and they never complained. They took care of every single pathology need that came through our doors and did it without complaint, without issue, and quite frankly, without subsidy. So I wasn't paying them to do this. They were good to us. But the GI group comes to me and says, we'll bring our cases to your hospital, but we have to have our own pathologist because we want to employ the pathologist and we want a cut of the revenue generated by the pathology we're creating when we do the GI procedure at your facility. So where do you land on this? Is that, I struggle with it because I kind of understand it. I don't fault the physicians for wanting to do that. I kind of get that. But at the same time, where is that going too far, or is that right in the wheelhouse of what should be acceptable?
All right. So I'm about to go, you sprung one on me. So I'm going to be controversial. So
good.
Think about it this way. If you and I have a roofing company, we like manual labor kind of stuff. So think of it in simple terms. If I've got a roofing company and my job is to go put roofing on houses, but over 20 years, you and I have this company, and over time we sit down and we look at annually or biannually, whatever, the cost of asphalt, the cost of materials keeps going up, cost of labor keeps going up. all these factors and inputs into our business keeps going up. Well, what do? Well, we have to raise our prices. We have to evaluate, okay, well, wait a minute, man, our margins are getting really low. We don't have money to invest back in the company, to buy new trucks and do whatever, whatever we need to do to keep the company moving. Healthcare's had the same problem. And there's a graph, and I wish I had it, my hands on it. I would send it to you right now. If you look at over the last 20 or 30 years, you look at GDP, you look at average wage, and you look at a lot of different things, and everything goes up. And there's one line that goes down, and that is physician income.
Absolutely. That is absolutely true. And it is in itself, it is tragic.
So you think about, okay, well, why? That sounds greedy. Why is the physician going to the hospital saying, look, we're creating this volume for you. There is a professional fee and there's a technical fee. Well, we should get a share of that technical fee, being that we're bringing that business to you. You and I used to hate to hear that as hospital administrators, because it was like, man, we don't have any margins to share anyway. Now you want us to share. But it's the reality. These guys are getting pay cuts on their pro fees. They're doing the same amount of work, doing more work for less money. They don't have a choice. We're driving them to that point where they have to look at, there's a phrase that I hear a lot, and it's called income repair. There is so much effort to do income repair for physicians that we shouldn't be surprised that that conversation is happening. And so, to answer your question, I think it's absolutely what should be happening, as long as this externality of this line, this 20-year line, keeps going down for physicians. We should not be one bit surprised that they are looking at ways to sort of supplement their income through sharing technical fees and that sort of thing.
Yeah, and I don't disagree with you. My problem is it created another problem for me. Because I wanted the volume. I like those doctors. I was good with them bringing more cases to my facility. That all sounds great on paper, but I'm also a realist that if I remove that income and that opportunity from my pathology group, what they are going to do is be in my office saying, we're not charging you a subsidy right now, so you're not having to subsidize us. We're completely independent, but we need one. So then, so theoretically, I want the GI physicians in my situation. I want them to have that. I'm good with it. I don't really care. I mean, I'm a free market economy kind of person, but I'm also sensitive to the fact that their benefit is going to be at my expense, because I'm probably going to have to subsidize my pathology group. And that's where, we create. Now, if everybody was part of the same organization, then it's a completely different discussion. But it's complicated.
Well, and this gets what can be fragmented, what can be aligned. It's, you know, it's I don't have an answer for that question, because I certainly remember the days that it's like, man, you guys pull any more volume out of my lab, I'm not going to have a pathologist, because I won't be able to afford, and I may not be able to afford to subsidize them right now. And I'm going to use anesthesia as an example. That's a service line where anesthesia is so difficult to recruit and retain and keep. And as a hospital, you don't have a choice. It's not like with the roofing company, we can decide, well, we're going to stop putting on that kind of roof because this roof has got a better margin. Hospitals don't have that flexibility. They have to, there's a large list of fundamental services that they can't stop providing in order to be a hospital. And at some, that's where these closures happen, is because, well, they've lost their margin and they can't stay open. And there's a lot of folks scratching their heads. I saw there was a meeting this past week with the HHS secretary, meeting with rural hospital CEOs, and I get, talking about this very issue, that they are usually the largest employer in that town, and they are a driver of the economy. But what's the answer? Is the answer to prop them up? I don't know. I think that's clearly not the answer, because who's going to prop them up? It's going to be the taxpayers. It's going to be whomever. And I'm a free market guy as well. I think there should be a viable system to do that. And this gets way off topic, but the third party payer system is wrought with problems. And when you disconnect those things, you don't have what would normally happen in a free market economy. Well, I'm going to figure out another way to put a roof on my house. It's too expensive to pay these guys to do it. I'm going to figure out another way to have shelter. I mean, I'm being oversimplified, but you know what I mean? It's like those are things that happen every day. We just make decisions. Consumers make decisions on how to do what they need to do in a way that they can do it. We're pretty resilient as humans. We figure that out. But healthcare is a challenge because it's just too disconnected.
It is. And, healthcare industry as a whole operates in a free market economy, but not in a free market industry.
That's right. That's exactly right. Yeah.
And my entire basis for saying that is a majority of the typical hospital or physician group, or just pick one, a majority of their income typically comes from government programs.
Yeah.
And then there's all kinds of rules and regulations on top of it. So it's not a free market. It's not.
Well, and it's the friction between this sort of idea that we have to maintain the public health. Hospitals are a huge part of that. All healthcare providers are a huge part of this idea that we have to maintain public health, which is a government role, but we're relying on the free market to do it. So we regulate the free market, but it has to meet this sort of this sort of public and governmental need. Um, yeah, I don't have an answer for that, but I think that's where the friction is that's where the mandates that we always struggled with, whether it was EMTALA, I know we talked a little bit about the EMR and HIPAA and all those sorts of things. It's just requirements that we need to have in various ways to support this idea of public health, but we're having to do it in a free market world that's competitive. And there are people that need to have a margin and making investments and want to have, all of these things that you would have in a capitalistic society, but they're running up against this idea that it just has to get done, you know.
Yeah. I just learned something new. You're an economics nerd just like me.
Yeah, I am. I love
Oh,
love macro.
it is. Oh, and micro and even better
Yeah.
behavioral economics. God, it's
Oh yeah.
gold. It is absolute gold. Okay,
Yeah.
so we've talked a lot about the providers. Let's touch on the tragic alignment related to payers.
Yep.
And that is something a lot of us agree on. So talk a little bit
Yeah.
about your perspectives of that.
Yeah, this was a tough one because it's going to be so controversial. You've Everybody has strong emotions and it's so regretful that's happened with the United Healthcare CEO. We're at a point now where it's just so volatile and we have, locally we have some contract dispute with a large provider and an insurance company um and there's just a lot of energy. I say bad energy, but there's just a lot of focus on it right now. So, and where does the tragic alignment occur? You know, I think this goes to the whole problem with I'm a customer, but I'm not paying for the service.
Yep.
I'm
Yep.
going to consume a service that you're going to
It's
provide.
moral hazard, talking about economics.
That's right. That's right. We really need to transition to that phrase because it's no longer about alignment. It's you and I are going to have a transaction. I'm coming to you, Dr. McDougall, and you're going to help me with my health issue. But this other people, I've joined this program with my enrollment to say, whenever I get sick, I need you to cover my costs. And they said, yes, we'll cover it. And here's all of these guidelines of what we're going to cover, what we're not going to cover. Well, I don't know how I'm going to get sick. And there's a billion different ways that's going to look. Well, I'm coming to you with my specific illness now. And your job is not to go through, well, Mr. Theriot, this is covered, but this is not covered. And here's what I'm going to have to do, what I would normally do clinically. But I tell you what, since you're not able to get this, let me do this and that and the other thing, and then we'll see what happens. Why does it have to happen that way? It's because we've got really smart people that are doing all that they can to not pay a dime more than they have to pay to maximize all of the things that have to happen in a risk pool. All of that's necessary, but it's too detached. And if I'm not experiencing that, then maybe I should have some sort of decision I make this better, And I don't want to go down the road. People get real defensive about, well, you can't say it's my fault. I've got heart disease. Well, I'm not saying it's your fault, but you're part of this solution. You've got to be part of this solution. And what does that look like, you know? And again, I don't want to be too controversial about this, but
Yeah.
we should own our health. We should absolutely own our health. And too many of people would just say, "Well, I've got this card. Here, fix me, doc." You
Yeah.
know, and that those days are gone. You can't do that anymore.
Well, and it gets really weird to me because it's a zero sum game. And some would argue I'm wrong on this, but you essentially have, and I'm going to simplify the heck out of this, but you've got four parties that are involved in providing care to patients. You have the hospitals, let's just put them all together, hospital surgery centers, anything that's a brick and mortar provider. So there's your
Yep.
first group. The second group is your primary care physicians that should be captain of the ship and directing care. And it doesn't happen because,
Yeah.
quite frankly, they aren't given the time to do it correctly. They're not
Yeah.
paid adequately for an office visit to where they can invest the time to do it correctly. But that's a whole nother topic. The third group are the specialists that get the referrals from the primary care physicians. The fourth group is the controversial group, which is the payors. And I'm sure people are out there thinking, oh, no, no, you just added them in. They're not part of the equation. They absolutely are part of the equation because of those four groups in a zero sum game, somebody's going to lose.
Yeah.
And I've always, my entire career, I struggled with a hospital owning an insurance plan
Right.
because if that insurance plan, I kind of get it to some extent that you want to have some amount of leverage when negotiating with the other insurance plans. I kind of get that part. But if my insurance plan that I own that is attached to my hospital has high margins, there's a real good reason why it has high margins because the plan has high margins and the hospital probably has low margins. You
Hmm.
can't have
That's right.
both. They can't both
That's
have
right.
high margins because the margins at the health plan are going to be high if they don't pay as much to the provider for the care. And so I've always struggled with this entire concept. Um, but it's those lines have started to get real blurred when you have large payers that are employing large groups of physicians, particularly primary care. And those primary care physicians, everybody's dependent on them. The last two parties, the hospitals and the specialists, are dependent on that primary care group for referrals.
Yep.
And the first thing they do is they ratchet down and create policies and barriers for referrals, and it just gets
Yep.
weird. Um,
Yep.
and, make no mistake, the people who are making money out of these four parties, it is the payers. I said it. I
For
said it out
sure.
loud. But you can, if somebody wants to question me on that, just go out there and look at the publicly traded healthcare organizations, meaning
Yeah.
hospitals. Go look at their margins and then go look at the payer margins. Tell me I'm wrong. But the
And listen, Tom,
margins are
as a
on the payer
proxy,
side.
you don't have to go very far because I think it's U.S. News and World Reports or one of these publications publishes the top paid CEOs in healthcare. 8 of the top 10 are insurance CEOs. I mean, and it sounds like I'm picking on them, but I guess we are. So, and I don't want to feed that monster that created that tragedy, but um, it is to your point. It has to. You want to talk about alignment? That's where that alignment breaks down. Is there is an alignment. They have clearly won. In this four-person struggle to provide health care for individuals in a way that's sustainable, the three parties have lost and one has won exceedingly well, and that is the payer. And any data set you look at, the margins have only increased for those guys, and everybody else's margins have gone down. Just to put a bow on alignment, is it possible? Yes, it is possible, but it's aligned based on what criteria? That's the part we've got to agree upon. And there's this, well, we should be aligned on outcomes. Okay, well then let's align on outcomes. Let's have everybody incentivized to have the same outcome. Or are we aligned on financial measures? Okay, well then let's be aligned on financial measures and not have Well, one entity in that four-person scenario is aligned on financials and everybody else is aligned on outcomes. Well, that's not fair because we're held to different standards. I think if we're going to get alignment, that's where we've got to go.
No, I agree completely. And it is going to require that alignment of incentives. And once we get to the alignment of incentives, but I think to some extent, though, because the fifth party that I didn't throw out there is the government. And I think to some extent, the government doesn't want us fully aligned because they are the largest payer of services. So if all the providers and everybody was suddenly get in alignment, again, zero-sum game, the government's probably going to lose. So they probably enjoy to some extent the fact that the commercial payers and the providers are not aligned.
Well, and I'm going to pick on you the same way I pick on my wife. We act like the government is this one unified entity and message. It's not. It's the embodiment of chaos. So,
you're
I mean,
kidding.
if we're relying on the government to get together and solve it, it's not going to happen.
Yeah. So the old phrase, the government's here and they're here to help. Yeah. Okay.
That's right.
All right. Well, good. Well, this has been fantastic. I've thoroughly enjoyed the conversation about this, but also have a list of other questions that I've got for you. So we're going to do a part 2. And so please, if you've listened to the first part, please make sure you join for the second part with Paul Theriot.
Thank you for listening to the Healthcare Badlands podcast. As always, please like and subscribe so you don't miss future episodes. If you have suggestions for topics or guests, please email those to podcast@badlands.pro. This podcast is for informational and entertainment purposes only and should not be considered legal advice. Some information shared may include fictitious names. The opinions expressed are solely those of the host and/or guests and are their own and not reflective of the opinions of others or our sponsors. Thanks again for listening, and we hope you'll join us on the next episode of the Healthcare Badlands podcast. Until then,